Good afternoon and welcome to the Bree Collaborative and Fletcher Group webinar, Building Recovery Ecosystems, Collaborative Approaches to Health and Housing. I am Amy Etzel, Implementation Manager with the Bree Collaborative. Before we begin, just a few quick housekeeping announcements. You all are currently on mute and will be throughout this webinar until after our presentations. Milena and I would love your participation in some polls that we've entered in throughout the webinar and a discussion at the end of our presentations. We'll be utilizing the chat box to facilitate this discussion at the end of the hour. This webinar is being recorded. I will be sending all of you a link to the recording of today's event and a copy of today's slides before the end of the week, along with some relevant resources. You may have noticed the closed captioning transcription at the bottom of your screen. In the spirit of inclusivity, the Bree will be using this feature in Zoom for all meetings going forward. If you would like to view and read the full log of this transcription, please look to the bottom of your screen and click on the far right option, View Full Transcription. The second option of the menu that will appear will bring up a dialog bar on the right side of your screen with a log of the transcription. Okay, let's get started. Milena Stott is going to kick us off with a little rundown of our learning objectives before diving into the meat of today's topic, the current recovery housing landscape throughout Washington and some frameworks to think about when approaching issues for your clients. I will then talk a little bit about the Bree Collaborative's opioid use disorder treatment recommendation and highlight how some of our recommendations can help bridge that gap between the medical community and the recovery housing community. And then we'll go back to Milena to take us even further into how to align medical and social interventions. So welcome and thank you to Milena for bringing us your expertise on this topic today. Milena Stott is the Outreach and Engagement Manager with the Fletcher Group. She is a healthcare systems expert who has held numerous titles within the industry, including Chief of Strategy, Chief of Transformation and Innovation, and Director of Healthcare Integration. She currently supports a number of initiatives in Washington that support building cross-sector partnerships. As an integrated care consultant, her work aligns with regional healthcare network goals, all of which serve her very well as an outreach and engagement specialist with the Fletcher Group. So I will now turn it over to you, Milena. Thank you.
Thanks, Amy, for the warm welcome. I'm very happy to be here today. I've worked in the behavioral health space for a long time here in Washington, and I'm really appreciating my journey as we explore health and housing partnerships across our community networks when we serve individuals with behavioral health conditions. So, my goals today here really are to kind of dip our toes in the water, so to speak, when we begin to think about how the health and housing sectors work together with one another here in Washington. And in order to do that, we have to have a little bit of an understanding of what the housing that is available here in Washington looks like. And then understanding what happens in those settings and what services are there and what do those folks need from us as treatment providers in the community. And then that dovetails into understanding what we can do to support clients in finding and maintaining their housing as one of the missions of our work. And then kind of diving into different ways to collaborate and support persons with their recovery goals, as well as just kind of at the end closing up with a discussion around barriers and future topics that we may want to see in this setting and conversations that we need to have as a system to help us move the dial. All right, so just as a grounding vocabulary, we wanted to just kind of talk about what we mean when we say the following. So clinical staff, we're typically referring to somebody within a care team that delivers medical care to an individual. When we talk about housing operators, we're talking about folks that provide housing for folks with behavioral health conditions. When we talk about housing subsidies, we're talking about monies that are used to subsidize rent or cover the full cost of rent. When we talk about capital construction dollars, we're talking about what we are using to build the actual structures that people live in. And when we talk about operations dollars, we're really talking about dollars that are used to support services and facility operations within the housing settings. You know, whenever we start a conversation, I always like to talk about theory of change or logic models, right? Where we kind of understand the reason why we do what we do. The BRE Collaborative and others across the state, including the Fletcher Group, really are focusing on this idea of recovery capital and health and housing and what that means, right? When I think of housing, I think of home, and I think of my home and what it means to call something a home. And a home for me is more than just a physical structure. And sometimes we think about home as a place where we're addressing basic needs. And I take that definition a little bit further, right? I think about home and its relation to community and all of the things that happen within a home. So the theory of change really here is that, you know, in order for individuals to fully achieve their potential or recovery, we need to have some basic things in place, right? I think that many of us in this webinar here today can agree that without adequate food and nutrition, warmth and clothing, and a roof over our head, it's pretty challenging to move forward with addressing our health and improving our health. And so we take that into, you know, once we have those basic needs established, what are the other elements or components that lead us to recovery? Whether recovery means being resilient, whether it means being employable, or whether it means being resource adequate, you know, what are the different elements of that recipe that have to come together to support an individual? And so we add in the elements beyond the basic needs of health, safety, and well-being. We know that mobility and transportation is important. We know that we need job and life skills to kind of navigate life. We know in some cases that also means, you know, access to more education. And then really this idea of social capital, right? That our social connections or our community networks help us become who we are. This slide here is really to illustrate the recovery support services framework that's available at the Healthcare Authority in its current form. And like our definition of home in the space, you know, the Healthcare Authority really does look at home in the element of health, home, purpose, and community. And they've funded a wide array of programs that support achieving that goal. Some of which have a focus on social determinants, and foundational community supports like housing support or employment support. Some of those services are more targeted to behavioral health populations with higher needs. But all are done with kind of this belief that, you know, health services and recovery supports are part of that recipe for recovery and resilience. When we talk about housing and system interventions, there's a few different ways to kind of look at the housing world, right? There's permanent housing, and our state has a few programs to support that. And we know that that's the goal for everybody, right? Permanent housing gets us that foundational element, Maslow's hierarchy, if you will, around preparing an individual to achieve resilience in their life. We also do a lot of work in funding temporary housing. In an ideal situation, those temporary housing settings feed into the permanent housing settings. And one of the things that Washington has done is created a coordinated entry process. And the goal is kind of this centralized location of access points throughout our state, you know, where folks access housing. And these coordinated entry sites have access to various programs and subsidies, so to speak, to help clients successfully get rehoused, stay housed, or get housing. There are also efforts for rapid rehousing. There are some populations that are not permanently homeless or chronically homeless. And so, you know, the rapid rehousing programs really focus on temporary assistance and case management support to get housed again. And then there's permanent housing, which is those ongoing subsidies and support services to keep people housed once they are housed. Some examples of temporary housing interventions, you know, include emergency shelter. That is kind of a safety net option, so to speak, where everybody can kind of come in and get shelter. There's a transitional housing element, which is really oftentimes facility-based. They tend to range in 90-day to 24 months. Of course, transitional housing, folks can stay there longer if there's a backlog in permanent housing or access to those type of subsidies to move beyond transitional. And then there's targeted prevention, right? Temporary rental assistance or case management for folks that are at risk of becoming homelessness. So you can see that there's kind of this broad array of services or housing supports that are available in the continuum for individuals who come into contact with the homeless system with various needs. And the goal of that coordinated entry point is, to communicate with providers and individuals seeking housing on supporting access to housing, and in other cases, maintaining housing. And that's really the importance, of the service providers, is sometimes people's needs extend what is available on site. And so there are some thoughtful service programs that come alongside the housing interventions to support that. So in terms of coordinated entry, right, the vision of coordinated entry is really that there's a specialized housing system that creates a one-stop access for funding resources and is able to triage. One of the things that we know to be true is that, there are many coordinated entry sites that aren't equipped to handle the queue of people. There is a prioritization based on level of severity. And so, related to access to housing or housing related funding, there are applications and processes that one has to go through in order to qualify. And oftentimes the relationship with service providers is super helpful in that process, especially when working with populations that have varying degrees of ability and knowledge to navigate those systems and complete those applications. So in terms of the housing continuum, I think about, we have different levels of care in the treatment world, and there's different levels of housing in the housing world. And really the job of a housing provider is similar to that of a treatment provider, right? In terms of understanding a person's need and eligibility, the different support services that have to happen in those settings in order for that individual to be successful. And so we think about housing as a continuum, right? And then people can move through different spots of that continuum in different points in time as their needs change. And as treatment providers, one of our roles is to kind of address what those needs are and how we support our clients through navigating those things. So in an ideal setting, there's enough affordable housing to go around for anybody who is ready to live independently. And living independently may not necessarily mean that you're not getting services. You may still get some community-based services, but the idea is that you have the skills and abilities and supports to be able to live independently in a unit. That's the golden ticket, right, for folks. Everybody's looking for a Section 8 or some sort of rental subsidy voucher to support their rental costs. So moving away from affordable housing, you have a lot of supportive housing services and sites. And some of these are permanent and some of these are transitional. And in the supportive housing sector, typically a person is homeless, but they have to be homeless to get access, or they have to meet a number of other eligibility criteria. And some of those are listed here, right? It's really around that prioritization for those who are most ill or have a certain number of risk factors that would suggest that they need this level of support. In those settings, it's not clinicians necessarily that work in those settings, though I have seen some programs hire clinicians within those settings because they've found that to be helpful based on the population that they're serving. But in general, those sites are either partnering with providers or working directly with clients to support their case management needs and their coordination of care. And there are various subsidies in our state that allow for those programs to be successful. Then you have recovery residences in Oxford, which is really the space that the Fletcher Group focuses in on. Nationally, there's a lot of effort around the National Alliance for Recovery Residences to make sure that homes are either certified or licensed with a certain level of quality to promote the evidence-based practices that are supposed to happen in those settings. And so here in Washington, there was some recent legislation that supported the development of some revolving loan funds for recovery housing, as well as an opportunity for training and certification for recovery home providers across the state. The Washington Alliance for Quality Recovery Residences is currently in the process of developing a database of all certified homes across the state. And they also offer quite a bit of training and technical assistance to homes that are interested in providing services and becoming certified. Then you have Oxford, which is probably better known in our state. Oxford is also a recognized best practice, and those homes tend to be peer run. In the recovery residence in the Oxford space, a lot of those homes are receiving clients or individuals who come into those homes with subsidies, including housing and essential needs, HARPS dollars, and criminal justice treatment dollars to pay for services in, or to pay for rent in the homes. The Washington Alliance for Quality Recovery Residences is also working with the state of Washington Healthcare Authority to develop some trainings around supporting individuals on medication-assisted treatment, or medication-assisted recovery is the term that they use in homes. And so really kind of sorting out the relationship between providers and those homes and how they come together to provide treatment for folks with opioid use disorders on medication-assisted recovery. And then there's residential treatment facilities. In this state, residential treatment facilities typically are the ASAM level 3.1 or higher. Most of our facilities are intensive inpatient, so shorter stays, but certainly there are models in recovery housing where longer stays are possible. And for example, in Kentucky, the Recovery Kentucky model offers 9 months of recovery-oriented services to people coming out of the criminal justice system. And the recidivism rates are super low and the reemployment rates are super high. And so definitely an opportunity to think about housing, transitional housing, the duration of treatment, and what it means to keep people housed while they're in treatment, and what that means for treatment success rates and things like that. And so when we think about our continuum, I like to think about it how people become eligible, stay eligible, and graduate out. And at any point in time, sometimes that requires the system to have the next level, the next lower level of resource available to the individual so they can exit that higher level setting. So when we look at funding housing, it's quite complicated, and I have so much respect for all of the housing providers that have made this work, right? Oftentimes as housing providers, we're trying to pull together HUD definitions and what do the federal subsidies require? And then how do our state programs offer what the federal programs don't offer? And then all the way down to the city and local level, I'm a part of a lot of conversations where recovery housing has become a central topic of conversation for communities where people are exiting treatment into homelessness and then finding themselves back in treatment or the jail. So related to subsidies, in our state, we have a few subsidies that we can use. The HEN and the HARPS program are state programs They are housing subsidies specifically for people with behavioral health needs. As far as housing subsidies, there's also what we call the HUD NED vouchers, which stand for non-elderly disabled housing vouchers. We also have tenant-based rental assistance programs. And then we have criminal justice dollars or criminal justice treatment account dollars that can be used for housing subsidies. Related to capital construction, right? So our state also funds quite a bit of construction. And when we speak to providers, these funds are super important, right? In order for them to balance their budget, so to speak, or set what they charge in rent, you know, they have to think about how much debt they incur through the process of construction. And the idea is that whatever debt that you incur, you have to pay back in the form of a mortgage, right? And so you set your prices for rent based on your operations budget, right? And that means services and housing operations. What capital construction dollars do is they offset some of those costs for the provider to lower their operations costs over time so that they don't need as much subsidy, right, to balance the budget year to year. Some providers get super creative, right? They use capital for construction, they use subsidies to make sure folks can stay there, right, and have that rent paid. And then they also partner with services in the community where those services are providing some supports to those individuals living in that housing setting so that they can stay living in that housing setting. I see a question. Does Medicaid managed care provide coverage for care management services to people in supportive housing environments? Yes, so there are programs like the Foundational Community Supports Program that provide coverage to support individuals getting housed and staying housed. And so an example of how some of that might happen is that somebody coming out of an institution needs housing, and the institution may complete an application for FCS services, refer it over to the third-party administrator who determines the eligibility and authorizes the benefit. And then the housing provider can provide some of those care management or supported employment services to that resident. You know, the FCS benefit can help people transition from institutions to access housing. And then once they get to that housing setting, provide the services that they need to stay housed. The employment benefit helps people receive support when they're ready to enter the workforce. And really is this relationship between the provider and the employer on how to support that individual in making sure they're successful in retaining their employment. So at that, Amy is going to join us and help me do a quick poll, because we are always interested in knowing, you know, we know that things are what they are on paper and then they play out a certain way in the community. And so as we begin to elevate the conversation about housing, your participation in this poll is super helpful. So we'd love to know from you folks that are out there, how often do your clients successfully access any of the resources, in particular the housing subsidies that I discussed?
Thank you for your participation, everyone. Looks like we're still getting pretty good engagement. We'll let this go roughly around a minute. I'll wait until I see it starting to slow down, and then I'll close the poll before launching into our second one. So we'll go for about 10 more seconds. But I think, Milena, the percentages we're seeing are what we anticipated, not wonderful access. All right, I'm going to end this poll, share the results. Do you want to say anything about this, Milena, before we do the next one?
Yeah, it's so here's what I will say. This doesn't surprise me, based on the anecdotal information that I have from the community. I will say this, the Affordable Care Act opened up Medicaid to a lot of people in our state. I don't have that exact number. I'm sure somebody on here does. And if you want to chat it into the chat box, please do. But what we know too is that all of our data and systems, right, are based on who we're serving. And we have this influx of individuals who are now eligible for Medicaid and coming into contact with our systems. And that means that they're in competition for the same resources that our system had designed for those folks that were on Medicaid previously. And so, what I will say, it's super important for us to understand the experience in the community around access to housing and what those barriers are, so that we're able to do things about them. The conversations are happening, so there is hope. And the more informed of a conversation that is, the better of a solution we'll be able to come up with. Amy, would you add anything?
No, I think you covered it well. And that leads very well into our next question, which is more about typical experience.
So what is the typical experience for your clients when looking for recovery housing?
And then we came up with our best guesses of what the current experiences are, but if there's anything that you would like to share that your clients are experiencing that are not listed here, feel free to enter that into the chat, please. Please share. Getting a wide variety of answers. We'll go for another 10 seconds or so. Okay, I'm gonna close when we hit a minute. So about 5 more seconds. Lots of wait list, which is what I think we also expected. Do you want to speak to that, Milena?
Yeah, I did suspect that it was going to be wait list. I'm pleased to know that knowledge of access and resources is not a barrier, though for those where that is a barrier for, we do have that at the end of our PowerPoint, is the various resources across the communities by county, where that's the case. I would also be interested, in taking it to another level for those of you that know where wait lists are maintained, how to understand a little bit more about those wait lists and what's happening within those wait lists and movement. And, are you able to reach clients who are on a wait list when their name comes up, right? Because as a clinician in the field, I often remember I helped a lot of folks apply for housing. Reaching them, following the application sometimes became a challenge, right? It's like you have an opportunity to engage people at a moment in time, and you don't know how long that opportunity is going to last. So big supporter of making sure that we have treatment on demand, right? Or services on demand when folks need them, because otherwise it could become a lost opportunity.
Absolutely.
Amy, there was a question that came in about the ideal relationship between a health plan, ideal health plan or health plan relationship look like to support members in need of housing. I feel like collaboration with housing providers and beginning to understand how to partner. I think that there are some regional elements. I have seen some regions develop some really nice community partnership collaborations where they're able to share information and address the problem collectively, right? I love to use the term asset-based community development. Mm. Every community has its own assets and has its own leaders. And when you pull the right people together in a room to solve a problem, I hate to sound cheesy, but magic happens. There's nothing more motivating when you work with a group of people that have a sense of urgency about a problem and are willing to divide up the work and research how to tackle it together. I think that health plans have a lot of data, and they have a lot of influence too in how contracting happens and how incentives happen and how collaborative investments happen. So I think that there's lots of opportunity there. But I would say, we spend a lot of time trying to create these coalitions, so to speak, and what I find is they work a lot better when there's buy-in and they're not forced and they're community driven. And that's a lot of the work that I do in the rural communities in Washington through the Fletcher Group, and how we are funded for the grant is really this community quarterback role, right? Where you have visibility into what's happening in different spaces, and you can provide TA or training or community collaboration, or create the space for collaboration, and then offer project management. Those are the solutions that I can kind of think of top of mind, but I'm happy to have further conversation with anybody who's interested. And I know that Amy has our contact information at the end.
I do. Yeah. Thank you all for your honest responses to these questions. We are going to dive a little bit deeper into some of these challenges later on in the hour in our facilitated discussion. And then Milena and I are planning to offer a follow-up webinar at the end of March that will bring in some policy experts based on the feedback we're hearing through these polls and the conversation we'll have at the end of this hour to kind of, brainstorm together and talk through some creative ways to approach some of these barriers. So stay tuned for that, and there'll be more information coming for that follow-up webinar. So now I'm going to move a little bit into the medical side of this topic for a bit and talk about the BRIE Collaborative's opioid use disorder from that clinical lens. First, I just want to give a very quick background on the BRIE Collaborative itself and our guideline development process. I know that some of you have attended these webinars before and have heard all of this, so I will try to be brief, but not too brief for those of you who are joining us for the first time. Just a background on the BRIE, we are a public-private group in Washington State formed by our state legislature in 2011. Our goal is to improve healthcare quality, outcomes, and affordability throughout Washington State. Our members are made up of healthcare leaders from around the entire state, and our members represent health plans, healthcare purchasers, both private and public, our state Medicaid agency and private purchasers, as well as representatives from delivery systems across the state and other quality improvement organizations. Every year, we select 4 to 5 healthcare topics or services that have variation in delivery or outcomes, that are used inappropriately or too often, or that maybe are not used enough, or that have a patient safety or equity issue that our community cannot address alone or in any other way. Our recommendations are formed by clinical committee or work groups made up of community members with expertise in these selected topics. This collection of volunteers meets for about 9 to 12 months. And then in the work groups, we review published literature, guidelines from specialty societies, the work of other quality improvement organizations, some national entities, and we also try to really get that patient advocate perspective. And then we look at programs and policies within our own delivery systems. All right. Oh, okay. Our opioid use disorder treatment report and recommendation was adopted in November of 2017 by our community. Each of our guidelines is usually framed around specific focus areas. And so our opioid use disorder report identified 3 focus areas to frame our recommendations around, when they are access to evidence-based treatment, generally meaning medication-assisted treatment or MAT, referral information for when MAT is not available on site or for those patients who do not stabilize in an office setting, and then integrated behavioral and physical health to support whole person care, essentially meaning making sure that there's that behavioral health component offered to every patient with any MAT services. The most relevant focus area for today's topic is definitely that referral information piece, as our main message here, and our goal is to improve the relationships and communication between medical and housing entities. We're all serving the same people, and we really want to help these communities thrive. And so I'm going to highlight some specific actionable implementation steps within each of these focus areas, but I'm going to go slightly out of order and end with that referral focus area just for the continuity of our conversation today. Now, I do want to preface all of this information I'm about to give on the BREEZE report by saying that our guidelines are written primarily for a medical community audience, and some of these implementation steps are very useful in a variety of settings, including those outside of the medical office. Part of why Milena and I wanted to team up on this topic is that, we continue to see the age-old issue of siloed care. And so I think helping each of these two groups represented here today, the medical and housing communities, see and learn about the work you are all doing will be extremely beneficial to serving your common patients and client populations. So the first focus area of our opioid use disorder treatment recommendation is about access to evidence-based treatment, meaning medication-assisted treatment, MAT, buprenorphine, methadone, naltrexone. I don't know if I'm saying that right, I apologize. And this focus area also highlights the importance of reducing stigma around opioid use disorder. I don't think that the MAT recommendations is new for most of you, so I won't spend time going over the details of each of these medications. Our full guidelines go into specific details, so please do read them if it would be helpful. A link to our full report will be available on that resource slide at the end of this presentation. What I do want to highlight about this area, though, is that our work group really emphasized a no wrong door approach to MAT, and recommends really taking the time to discuss all options and associated risks of each of these medications with your patients so that they receive the care they need at the time they need it and on their terms. Also really take the time to discuss anything that may impact selection of medication, including whether the patient can do daily visits and the patient's use of other substances, particularly alcohol and benzos. Having patient education materials available on each of these treatment options in both the medical and housing locations really facilitates the patient feeling engaged with their treatment and feeling empowered within that treatment plan. Recommendations specific to the providers in our audience today, we really recommend having clear prescribing guidelines for your organization and provider teams to follow so that you're all on the same page as much as possible. And then we also remind providers to use the Washington Prescription Monitoring Program when writing any new prescriptions. And then, as I mentioned, we also really highly emphasize stigma training for staff. This last one, I think, is quietly one of the most important pieces of our recommendation. We highly recommend training for all staff on all levels, all the way up to the front desk, on the stigma associated with opioid use disorder and treatments to ensure that everyone in clinic fully understands and sees that opioid use disorder is a chronic, relapsing brain disease. Subtle word choices can truly affect the overall patient experience over the course of their treatment, and being very careful about the words chosen, even down to the detail of specific words used when writing a chart or case note, can have a really big impact. Take that time to educate yourself and your teams about stigmatizing language. I put in just a snapshot of a resource that I just love. In the before times, we have this up on our fridge in our office break room, and it's a simple reminder of the impact that words have. I'm going to email out this resource with the slides and the recording later this week. The next focused area we'll talk about is integrated care between behavioral and physical health. It's obviously such an important topic and one that there's a lot of momentum around the state of Washington on. This relationship between behavioral and physical health, even outside of the opioid use disorder space. But specific to opioid use disorder, this integrated approach is especially valuable when behavioral health is offered up with MAT services. We really want to emphasize the importance of that whole person care. Again, not going to be a surprise to anyone who's been working in this area. We've all seen the studies around past trauma and ACEs scores and co-occurring behavioral health needs among people with opioid use disorder and how important this behavioral health component can be in improved retention rates and overall treatment success. To help this whole person approach become second nature to provider and staff through that opioid use disorder lens, we recommend training for staff on the impact that opioid use disorder has on a person's overall health, and then really digging into helping staff understand an integrated care framework and building that foundational knowledge base on the importance of integrated behavioral health and primary care. I know that time, especially now in COVID, is so precious, and it can be hard to carve out time for training and take time away from direct patient care. But we just really want to encourage you to think of this as one vital part of patient care and how much of an impact this can have on that overall health of the patient and the retention rates that ultimately contribute to better patient outcomes. There's lots of resources out there on integrated care, including, and obviously I'm not biased, we do have the BRIE Behavioral Health Integration Recommendation from 2018. I'm happy to talk about any of these resources and help point people towards some more in-depth integration resources after the webinar. Integration of behavioral health and physical health is a particular area of expertise and interest for me. The last focus area within our recommendation that we'll discuss here is about referral to treatment when MAT is not available on site and or for those patients who are not stabilizing in an office medical setting. We highlight this area in our recommendations specific to medical settings, but this referral pathway and having very clear processes in place with no ambiguity around who does what within that process will obviously apply to referrals to housing as well. The best step you can take around this, may sound simple, is really to have a thorough and easily accessible inventory of the regional options for prescribers, behavioral health organizations that offer that behavioral health component of MAT, local opioid treatment facilities, and recovery housing. Take the time to build an easily accessible resource for providers and care coordinators to use and familiarize yourself with the local options. And also make sure this is reviewed and updated fairly regularly, as we all know funding and things like maybe a global pandemic will affect these options. When you have that asset map and inventory in place, also take the time to try to build in time for your staff to build up your relationships with these organizations and providers to ensure smooth, supported referrals and transitions and coordinated care as much as possible. I do know we talk all the time about how hard bidirectional care is, and I'm not going to argue with anyone about how difficult it can be. And we have to keep trying to build up these relationships however possible and however incrementally. Taking that time to build up this inventory and those community relationships with your local resources can have such huge returns for your patients. Another huge piece of this focus area is that really clearly defined referral process. I know I've said it before, I'm going to say it again because it's so important. A lot of times I hear from clinics that I work with, they have a clear referral process, but then when you really talk individually to the providers, it is not standardized across teams, and it can remain ambiguous, and there's ambiguity for people. So having those very clear referral processes, and then also it just helps ensure that nothing falls through the cracks. And then having that supported component makes such a big difference. So having a facilitated supported referral, meaning that that's verbal confirmation from both the facility and the patient, that support piece to the client is just so important. Having a designated staff, if your budget allows, to help a patient navigate any barriers like cost or transportation can really go a long way with patients and encouraging them to keep that referral and maintain treatment once they're engaged. So that is my quick little blurb, and now we're going to turn it back to Melina to dig a little bit deeper into aligning these interventions.
Thanks, Amy. I love what you said about that, create the opportunity for people to develop the relationships, right? In the same way that we want to be accountable to those we serve, we want to be accountable to each other and how we support one another in serving folks. I often found that, the state and health plans and, the powers that be can create that infrastructure that we need. Until the relationships are developed, it's challenging to make that a fluid process and therefore fluid experience for the person. I was a clinician for many years, and one of the things that I helped my clients do is access housing. And honestly, it was that taking the time to build a relationship with the providers and putting our heads together to solve a problem that really reached the outcomes that we wanted to see for our clients. People asked me what I was doing differently than what they were doing. I said, well, I know the resources first, and then I get to know the people behind the resource and make sure they're my best friend. And it works out. And, we experience satisfaction and success in that dynamic as well. So super supportive of that recommendation and those connections. One of the things that I think about, and I think that this is somewhat of a newer conversation, though maybe it's also just circling its way back around with different language, is this intersection of medical models and social models, right? And where they intersect. We talk about treatment continuums quite a bit, and a colleague of mine at the Fletcher Group said, I don't like the term continuum. I like the term ecosystem. And I got to thinking about, like, what does that mean, the term ecosystem versus a continuum? Well, an ecosystem involves everything in the community, not just the medical interventions, right? And we see with the emerging social determinants of health work that medical interventions account for a certain percentage of our outcomes, but that some of our other outcomes comes from investment in social programs to help people achieve recovery, right? Or build recovery capital or resilience or whatnot. And so when we talk about aligning medical and social interventions, I think the health and housing partnerships falls in that realm. There's a lot of community-based organizations doing employment support and housing support and life skills training that fall out of the medical world. Those organizations are often funded by grants and other private donations. And they have a huge role in the success of our clients. And so when we talk about referrals, in this section, we're specifically talking about referrals to housing and how you work with housing operators as individuals they house have emerging needs. Say for example, somebody's on medication-assisted recovery and they have a relapse. Well, there's many housing settings that aren't discharging people for having a relapse, which is what you're supposed to do. And if you have to discharge somebody because you can't care for them, then you also, should make referrals to other settings that are appropriate. But so in that context, we're really going to talk about how we use assessment and client experience and relationships to support aligning medical interventions and social interventions. So I referenced this term just a moment ago around recovery ecosystems, right? And when we think about recovery ecosystems, we can also think about different points of entry. So if I want to create a recovery ecosystem and I can accept folks from various referral sources, right? The criminal justice system often has criminal justice treatment dollars or DOC vouchers, for example, that can provide a housing subsidy for folks. Treatment providers can access things like HARPS or HEN to help people get access to housing subsidies. Counselors as well, other community support groups, or maybe it's a self-referral. But the idea is that folks can come in from any of these settings into a recovery ecosystem and receive support. And what we traditionally think of, in the medical model is this idea of integrated care or whole person care, as we're doing here in Washington. There are also all of these other things that help a person get better, right? I often think about, do we need to fix people? Or do we need to provide them with the opportunities that allow them to be healthy and successful? And obviously, oftentimes there's a little bit of both, right? That needs to happen. People may need a medication for a specific condition, and the medical system is able to do that. And once they have the medication, how do they re-enter the community and engage in the behavior change that they need to engage in, or receive the opportunity that they need to be able to achieve, employment or resiliency or recovery, whatever their goal is, right? Everybody has a different goal, but maybe we can agree on the term reaching their full potential. So what's the role of the, treatment provider in that? Every time a person comes into contact with a setting, a treatment setting, there's usually an assessment. Sometimes that's all we deliver, right? Because we deliver the assessment and they go somewhere else or they don't come back. But really the goal of the assessment is this idea, and I think about it as, what tools am I using to gather information? What information am I gathering and why? And what does this assessment tell me about the person and where they are in their stage of change, and what, services or interventions in the community are available for that person, right? Certainly, I don't want to put somebody who doesn't want to stop using substances into a facility where they're required to abstain from use of substances, right? So that's the most clear example. But we often put folks in settings based on what is available and what they qualify for. And I really challenge us to think about, when we do that, how are we then going to make sure we support the individual in that setting to make sure that they are successful? Part of our role as treatment providers is to help people experience treatment success, which requires us to have good information to help them make the decisions that they need to make to achieve that success. So how does our assessment really align where the person is at and what they need with what's available in the community? And once I know that, how do I then help them navigate into that space and develop a relationship with the person who's going to be receiving them, so that when there's a hiccup in that housing setting, they call me for support to problem solve rather than asking the person to leave. And then the last element is that partnership and collaboration, right? When we find that folks aren't placed in the right setting, or what we're doing for them isn't, what they need, or they change their mind, how do we align ourselves with the partners and networks in our community and collaborate with them to get that person the right level of support or the right care? As a person who's worked in a residential treatment setting, I see people come back, right? I used to see people come in with the highest of hopes, and it was always unfortunate that when I referred them outside of the center to services in the community, sometimes they weren't successful because there was a big element missing. Oftentimes that element was housing. So in terms of resources that we have available for you, we have pulled together a list of resources related to what we've talked about in our discussion today. I also know that Amy and I would like as much feedback from you as possible on certain elements. So I'm going to turn it over to her while I read some of the comments that have come in through the chat.
Yeah. I'm just, considering we have 7 minutes left and we didn't leave as much time as we'd hoped for a discussion, I'm just gonna go real quick. The first one is, I think, what will be the most relevant for the housing community audience. It is the DSHS Aging and Long-Term Support Division resources. If you click on this, there's then links for each county that will show you resources. So it's very specific, right down to the county level. It's super regional, and I think that's a good resource if you're not already familiar with that website. Shameless plug for our BRE Collaborative Opioid Use Disorder Report and recommendations and some of the implementation resources I built, as well as a previous webinar we did last year on our digging a little bit deeper into opioid use disorder treatment in a medical setting, and then a few other links relevant to supporting these communities. And then, this is just a save the date for that March 31st webinar that we talked about. Information about how to register for our webinars always comes from our mailing listserv. So if you're not already plugged in there, feel free to log in and then to sign yourself up. And then we've got contact information for myself and Melina. So these slides will be going out to you tomorrow, or at least by Friday, so you'll have all that contact information. And then we'd like to spend the last 5 minutes just talking through some of the successes and challenges, and really we would like to take the feedback we hear from you to inform who to bring in for that collaborative discussion in our March webinar that we're hoping to offer for you all, to bring in some very strategic policy and clinical thinkers who are either tackling this issue, maybe already have momentum around some of the successes and challenges and barriers we hear from you today, and then think about how to break down some of those barriers. Anything to add there, Melina?
No, I mean, that input would be wonderful, because we want to spend our time on developing something that's meaningful. I did want to ask a question out to the group and see what kind of responses we get in the chat box. But do physical health providers help people with SUD find community support services, and in particular housing? I don't know. And I think some of that question speaks to, how much information is out there about these resources and, depending on which setting you work, how you work with people and what resources you access. So
And I would say from the practice transformation work I've done, it very much depends on the bandwidth of the staff. Do you have a care coordinator on staff? Do you have a social worker on staff who can help with that? The actual physical health provider may not have time, but hopefully someone within the care team, the goal is that you have somebody to help with that supported referral, to do some follow-up, do that bi-directional communication. But especially now in COVID times, bandwidth is extremely low. Staff is on forced furlough. And so it's just gotten harder and harder and harder over the last year.
Yeah, thank you for that comment, Amy. One thing that I hear is like the funding, right, to hire those staff, right? Yep. So I think about for the places that have those staff, what magical funding or what magical finance model have you come up with to allow for that service? Are you getting grants? Is this something that you're funding because it's effective? I'd love to know how folks are handling that.
Yeah, please enter into the chat or the Q&A box. I see you. We have in the question, someone from Wisha, Abigail, has asked, is anyone working with Built for Zero? So we were hesitant to sort of do an unmute all just because of the size of the audience that had signed up for the webinar. But if anyone would like to be unmuted, if they have any relevant information for Abigail on Built for Zero, enter your name into the chat and I'm happy to unmute you, and or we can provide emails to people to continue this conversation. And then Gretchen has put into the Q&A, in Oregon, Medicaid allows for peers and community health workers to be billed under supervision as the rendering provider. There are also many barriers there. And then Abigail saying maybe something to explore the Built for Zero for the March 31st webinar. And so we'll take note of that for sure. Absolutely.
Yeah, that piece around Medicaid billing, there was another element around, the role of managed care, or another question around the role of managed care and encouraging linkage between physical health and behavioral health services, and then community support services.
Absolutely. I think that what I was most looking for, we'd really want to hear what has made those relationships successful. We talk about building in the time to build the relationships with our community partners. Is that really what it is just the time and the extra effort? Or are there other elements that people would like to share or could share with us? And then as well, the challenges. Obviously, funding is always an ongoing challenge for people, lack of resources in your region, particularly in rural areas.
So someone wrote that they participate in the homeless network of Yakima County and Yakima County homeless coalitions. We also had somebody type in, instead of thinking about ecosystems, think about collective impact, right? And how we can come together to move, every resource in a direction to achieve an objective.
Absolutely.
Thank you for those comments.
Yeah. So we are at the end of the hour, and I want to be respectful of people's times. But again, Milena and my contact information will be available within these slides, and I'll be sending out the slides and the recording, and we'll put Milena, it's usually a blind copy sent out to all of you, but I'll make sure that Milena and my email addresses are visible. We love to continue this conversation. I know this is a passion area for both of us, so more to come. And we really appreciate your time with us today. Any final words, Milena?
My only final word is that under the HRSA grant, the Fletcher Group does technical assistance to increase the quality and capacity of recovery housing in rural communities across Washington. And so if you fit that box and want to have a conversation, please feel free. I actually encourage you to please reach out to me.
Yeah.
Hear your community experience.
And I did see one more question. I will be sending out the slides as well as a link to the recording as soon as we download it off of the cloud. And so those will be going out to you tomorrow or Friday, and as well as that stigmatizing language resource. So more to come. Thank you, everyone.